morning, good afternoon, and good evening, depending on which part of the world you're in. I am delighted to share this next entry in the series of keynotes, prestigious keynote series for the Hamlyn Symposium. And today I'm introducing a close colleague and collaborator from the Chinese University of Hong Kong, Professor Philip Chiu. So Philip is a professor of upper GI and metabolic surgery in the Department of Surgery, the director of Endoscopic Center within the Institute of Digestive Diseases, the director of the Jockey Club Minimally Invasive Surgical Skills Center, the director of the Chow Yok Ho Technology Center for Innovative Medicine, and the associate dean for external affairs in the Faculty of Medicine, all within the Chinese University of Hong Kong. And of course, Philip is also the director of the Multi-Scale Medical Robotics Center, which is a partnership between COHK, Hopkins, ETH Zurich, and Imperial, which is allowing us to develop the next generation of soft robotic platform for general surgery. So Professor Chiu graduated from the Faculty of Medicine in the Chinese University of Hong Kong in 1994. He became Fellow of the Royal College of Surgeons of Edinburgh and the Hong Kong Academy of Medicine in 2001, and received his Doctor of Medicine in COHK in 2009. Philip was also the first to perform endoscopic submucosal dissection for the treatment of early GI cancers in Hong Kong in 2004. And in 2010, he performed the first peroral endoscopic myotomy in Hong Kong, as well as pioneering the world's first robotic gastric ESD in 2011. Not surprisingly, given the context of this symposium, his research interests include esophageal cancer management, minimally invasive and robotic surgery, and novel endoscopic technologies for diagnosis of early GI cancers. He has published over 200 peer-reviewed papers and 6 book chapters. He received numerous prestigious awards, not surprisingly, including the State Scientific Technology and Progress Award from the People's Republic of China in 2007. And more recently, he received the gold medal with congratulations from the jury at the 47th International Exhibition of Inventions in Geneva in 2019, and the Spirit of Hong Kong Award on Innovation in 2020. He's currently the co-director of the journal Endoscopy and subject editor for Surgical Endoscopy. So today, Philip will describe his work on flexible endoscopy from flexible endoscopic robot for the treatment of gastrointestinal cancers from bench to clinical application, which I am looking forward to moderate in this session. So Philip, over to you. Thank you very much for being with us today.
Thank you so much, Ferdinando, and for your kind introduction. And of course, we are really closely collaborated nowadays and in this arena. So I'm really happy to share and to congratulate the success of Hamlyn Symposium this year virtually, and looking forward next year to be physical.
Yeah,
and
so do I, indeed.
So firstly, let me share my screen of the presentation slides. Okay, I hope all of you can see that. Okay, so now this topic is about the flexible endoscopic robot for treatment of GI cancer from bench to clinical application. So back in 60 years ago, in fact, endoscopy is being developed at the very beginning using the concept of a camera putting through a flexible platform so that we can take picture inside the GI lumen. So if I break down the design of the first endoscope, which is an endo camera, it includes the light source, optics, and processor, which is the camera. And still, after 60 years of development, if we look into the modern endoscopy in 2020, we can see that there's a significant improvement in the light source. Nowadays, the latest system using LED light, optics, processor, CCD or CMOS, but from the therapeutic potential of the endoscope, we are only given with a working channel, and that's the advances. So what can be improved, which part of endoscope can actually be improved by technology? I think first of all, for the image processing and analysis, recently we see the introduction of AI diagnosis. So this is the performance of the Endo 8, which is the developed latest system of the Olympus company. And the courtesy video given to me by my colleague, Dr. Louis Lau. Actually, you can see that the detection of polyps can actually be enhanced by AI technology. So even when our endoscopists cannot see those polyps, the AI system already being able to detect even smaller one. For steering and locomotion, I think image guidance or sensing will be also important, as well as robotic technology. But I think one of the key issues after detection of this early cancer is how we can treat it by endoluminal approach. And this will be definitely improved by the use of robotics. So the trend in endoscopy for the next 10 years, with the improvement in the efficacy and quality of diagnostic endoscopy through AI technology, through standards and quality control measures, we can detect more early GI cancer. They do not need surgical treatment. They will rather need a therapeutic endoscopy. So that's the key in development. So when we are looking into treatment of early gastrointestinal cancer, if their cancer is located within the lumen, in the mucosa, with minimal risk of lymph node metastasis, then the treatment can be just endoluminal resection, taking part of the mucosa away and with a submucosal dissection without necessarily resect the organ. So endoscopic submucosal dissection has been introduced by our Japanese endoscopist expert, and this is a way to dissect this early GI cancer away. So you can see this is a video of myself performing ESD for a rectal cancer. So we do not need to resect the rectum. We rather preserve the rectum so that the patient's function of the organ is preserved, or otherwise, if the lesion is really low, they would probably need a terminal end colostomy, a stoma. So the better quality of life will be enjoyed by the patient, and also a better post-operative outcome because there's no wound, no endosmosis. The patient can have an early return of GI function and a shorter hospital stay. So this is a prospective randomized control trial comparing ESD versus laparoscopic gastrectomy at our unit, showing you that even if we think that minimal invasive surgery is minimal invasive with little trauma, but ESD actually is better in terms of a shorter operative time, shorter hospital stay, and significantly a shorter time to enjoy full diet and lesser complication rate. And especially when you look at the pain score, we think that minimal invasive surgery have a minimal pain, but ESD have an even significantly lower pain score as compared to laparoscopic gastrectomy. And also you can see the CRP level was also lower, meaning the inflammatory marker is also lower for ESD. But however, ESD is difficult to start or to learn. This is one of our workshop outcome, training endoscopists, either gastroenterologist or surgeon doing ESD. So when they first perform this training in an animal model, actually they end up in 62% of a perforation rate. So one of the reasons why this is so difficult is that the design of the flexible endoscope with the performance of ESD require the knife to be attached to the forehead. So your scope is actually moving with the knife, meaning your head is moving with the knife and together with your eyes. So like that, this is a courtesy video photo given to me from Professor Nakajima in Osaka. So demonstrating this difficulty of how you can actually manage your meal. But normally we actually eating with the fork and the knife with a distance away from the target. So this is also a similar concept demonstrated for minimal invasive surgery. So my procedure of robotic gastrectomy, you can see a very stable platform. The dissection is performed by the two robotic arm with a 3D endoscopic image, especially when I'm dissecting the lymph node at the splenic artery and hepatic artery here. I have a very stable platform, good hemostasis, nice tissue retraction, and also exposure. So I think the future of therapeutic endoscopy required a better imaging, probably a 3D or 4K imaging. But now the endoscopy is moving towards that. And secondly, is a better tissue retraction or dissection devices, like a multitasking robotic platform, or a better tissue approximation devices by robotic suturing or stapling devices. There has been a development of flexible multitasking endoscopic platform, So using mostly mechanical design purely. So like the Enzo Samurai from Olympus and the direct drive system from Boston Scientific, or the latest use of the dilumen from Lumindi. So they are trying to achieve a triangulation approach and like a surgical approach with a mechanically designed platform. The issue is that the translation and also the accuracy is limited by the use of a mechanical design. So there are actually some robotic platform being also developed over the past 10 years. So with the collaboration between National University Singapore by Professor Lawrence Ho, Professor Louis Free from Nanyang Technological University, who is our chief engineer, and I'm serving as a clinical advisor, we actually developed this master and slave transluminal endoscopic robot. The idea coming from the crab core, like a crab, using the crab to perform the dissection. So this system was initially tested in some novice, and this is a design of that system. And using a bench ESD model, we actually compared between an expert endoscopist, non-expert endoscopist in ESD, and also novice engineer. So this video demonstrates that one standard endoscopist holding the endoscope. So this is a ESD procedure performed by expert endoscopist, and you can see he immediately can control the two robotic arms to perform the same procedure of ESD. So like that. And the novice is actually an engineer. Actually, she has no experience in ESD, so we require a lot of training. A trainer is next to her on how she can actually perform the ESD procedure. So by controlling the two robot arms, she will be able to achieve a good grasping. But however, the dissection time and the speed is much slower because of the inexperience. So looking into this outcome, actually the time to achieve mucosal retraction, submucosal dissection, you can see the green bar representing the novice. They are much slower than the expert or the non-expert endoscopist. But the time actually no significant difference, meaning that even with a novice by training, they will be able to achieve the same procedure with the robotic system. So this system, the first prototype of master will conduct with a clinical trial in Hong Kong and Hyderabad. This collaboration includes 3 patients from India and 2 patients from Hong Kong with early gastric cancer receiving a robotic gastric ESD. You can see that the procedure time ranges from 26 minutes to 68 minutes. So this is a video to demonstrate a proof of concept trial. So using the 2 robot arms, actually this 2 robotic arm was built on a conventional double channel endoscope. So this is a commercially available system. And when we are using these 2 robot arms, one is for retraction, the other is for submucosal dissection, we will be able to achieve a good exposure and avoid perforation of the GI lumen while completing this submucosal dissection. So frankly speaking, this system has a limitation because this is a first prototype, but we use the same concept of robotic surgery, the surgeon sitting on the console while the endoscopist is holding the robot, the endoscope. So by performing this procedure, we can safely achieve a submucosal dissection. But that system is only the first prototype, so you can understand we need to develop the second generation after the first success. So this system was moved forward by a new startup company. This is the Endomaster EC system. It developed with an independently designed flexible robotic platform, built-in endoscopic imaging system with 3 channels, 2 for the robotic arm, 1 for accessory. And this is a concept of the Endomaster EC system. So with a surgeon console and also the patient side card. And then you can see the 2 robot arms will be passing out through this redesigned flexible robotic platform, endoscopic platform, so that we can perform ESD procedure. So we have tested this system in a porcine model. So this is one of our experiments of performing a submucosal dissection in the lower GI tract. It's in the rectum of a pig model. So after initial mucosal incision, then we perform a submucosal dissection with the lifting using the left robot arm. And you can see now, after opening up the mucosa adequately, then we can lift up the mucosa and expose the submucosa. So the arm is actually designed with a best ergonomic position. So one coming from 9 o'clock, the other coming up from the 6 o'clock position. So if we need further injection, we can use the accessory channel as well. So the dissection and the retraction can be in a different angulation. So when we are performing this procedure, very importantly, we focus on avoiding a perforation at the base. So this procedure is being performed in a palsy model under general anesthesia. So this is the final part of the procedure. And after cutting, we can take the specimen out using the same system. So this data of a 5 palsy model experiment has been published in GIE last year. The average operative time is 73 minutes. The dissection time is 51 minutes. And the size of the specimen is actually quite big. It's around 4 to 5 centimeters in general. So with this experience in mind, then we actually start our clinical trial last year in May at the Endoscopy Center of the Prince of Wales Hospital, Hong Kong. So this is the room setting. This is our endoscopy suite. So we can actually perform this procedure in the endoscopy unit, not in the operating theater. So the patient was actually placed here with the anesthetist and the anesthetic machine being positioned here, while we have one endoscopist standing next to the patient and with one nurse, and the surgeon console is actually over this side. So this is our video to demonstrate the procedure in a clinical trial when one of the outpatient. So this is a fast forward video of 5 times speed. And the robot arm is coming up from the same 6 o'clock and 9 o'clock. And initially we need some juggling action in order to relax the wire. And this video lasts for around 4 minutes, 30 seconds. So the whole procedure is around 25 minutes. So after juggle action, then we start the mucosal incision. So remember that this procedure is performed by a robotic system passing through the flexible endoscope. So the patient, although it's under general anesthesia, will not have any wound over the abdomen. So initial dissection will be over the mucosa to open up the mucosa. And after opening up the mucosa, then we use the left arm to lift up the mucosa and then to continue the submucosal dissection. So during this process, we also learn a lot of new things because with this kind of submucosal dissection, the left arm, we can imagine that we are usually lifting up the mucosa. But in fact, the retraction can also be very diversified, like even compressing on the colonic fold to expose the submucosa. So now you can see there may be some limit in the lifting up because of the limit in the design of the robot arm. But we can move the retraction to left or right, or even compress over the far side or the near side. So it's kind of a very good intuitive way to achieve a good exposure of the submucosa. So now not only lifting the mucosa, but compressing on the mucosal fold to expose the mucosa can also help us to expose this lesion. So for a surgeon, one of the key is to expose the dissection plane. So any good exposure, after adequate exposure, a surgeon can actually perform the surgery with the best quality and safety. So during the procedure, we put the patient under general anesthesia to ensure the patient's safety and also, minimize the patient's movement. And the insufflation that we are doing here is by CO2. So carbon dioxide insufflation helps to reduce the abdominal distension, and the gas will actually be passing away very soon. So during the dissection, if there's any bleeding, we will be using the diaphragm resetting and the same electrocautery knife to stop the bleeding. A lot of the time, we can actually stop the bleeding. Or in this perspective, if there is any bleeding, because the dissection plane is so wide, we can dissect over the other side, avoid the bleeding side. And usually when we come back with the bleeding side, the bleeding already stopped because this is only small arterial or capillary bleeding. It can be stopped by itself. So you can see this is almost the final part of the dissection, and we are continuing using the same robot arm. So in this case, the endoscopic view is very clear. If it's not clear, we can have a water jet to wash the lens as well. So you can see that also with the bleeding, we can always have a water jet channel from around the 7 o'clock position to clear up the wheel so that we can continue the dissection. So this is the final part, and we can take out the specimen by the 2 robot arms. And this is the specimen size, which is around 3 centimeters in diameter. So this is one of the way to develop the system with a totally redeveloping or disruptive endoscopic platform and the arm. So the other is in fact sustaining on the existing platform. I think this is also an important concept because we don't need to redesign the platform. So this is one of the robots that we designed at the Chinese University of Hong Kong using the the USGI transport. We developed a similar concept of the 2 robot arm, and with the dissection and the lifting ability. And this is our system with the computer control interface and the master console and the robot arm. And we are actually testing this system in the animal palsy model. So with the same concept, now we will be able to perform ESD procedure using the 2 robotic arms. So this USGI platform do not have a built-in imaging system, so we need a 5 mm flexible endoscope passing through a 3rd channel. But at the same time, our endoscope can actually move closer to the endoscopic target so that we can focus on the dissection. So there may be also some advantage of using this USGI transport system with an additional channel for the imaging system. So a similar concept in the porcine model, in the stomach, we can perform a ESD procedure using a 2 arm. So same proof of concept study with this 2 robot arm for the dissection. So in our study, a total of 3 porcine models were being used for robotic ESD, and the specimen size is around 35 by 40 mm. Operative time is only 21 minutes, and tendon success is 100% without any perforation. So you can also see this is a single operator learning curve, but demonstrating that the 3rd procedure would in fact a much shorter operative time as compared to the 1st and the 2nd, and the area of dissect per time will also much significantly improve at the 3rd procedure. So this is our latest system with an enhancement in the development that you can see that we have a reinforced robot arm and much better ergonomic and intuitiveness with a better control of these 2 robot arms. And also the kind of mechanics behind the design of this control of the robot arm will also improve. So hopefully we do not only perform endoscopic resection, but also performing tissue manipulation and also suturing procedure in the future. So these are just a preliminary prototype experiment. And also for the development of the Endomaster system, they are also currently developing the suturing system for the Endomaster. So the potential application of this robotic suturing will be huge. I believe only managing GI emergency like bleeding or perforation, but also performing some morbid obesity surgery by endoscopy like endoscopic sleeve gastroplasty or even endoscopic full thickness resection. So the other system that has been developed, for example, like including this system, is called the Medical Robotics system. This is a published data from a clinical trial, and demonstrating that this system will be able to perform the ESD procedure in the colorectum. And so this system currently is past the US FDA approval for robotic assist surgical access to oral, pharynx, hypopharynx, and larynx for age older than 22 years, or robotic assist surgical access to anus, rectum, and distal colon for adult. So this system cannot pass to the beyond the distal colon, unlike the Endomaster, where it can actually achieve as far as the right colon. And this is another system developed from the ERCAT IFU from France. So it's endoluminal surgical triangulation 2.0. So this is a published data to demonstrate the use of this triangulation approach for performance of ESD in a porcine model. So basically a similar design of the robot. So this is basing on the previous mechanical design of an endoscope from Karl Stoss. And you can see that the similar ability of having different instruments for retraction and dissection. And this is also another system that developed from India, from gastroenterologist Dr. Amit Medio, my good friend. So you can see this is the system, the latest system from India. I think he's still developing this system. So we'll stay tuned to the performance of the system. So I think in the future for endoluminal robot, now we are starting on the clinical trial of the Endomaster system for ESD. 30 patients has been recruited for the trial, and hopefully in the future we can have a 3D imaging, 3D endoscopic imaging, just like Da Vinci, and also with a novel device like suturing and dissection by robot. And we can also think about automation in endoscopic robot based on AI technology. And I hope that with all this technology, we can enhance the development of endoscopic surgery so that patients do not need to receive surgical resection of an organ with an early diagnosis, early treatment through endoscopy. So this is my final slide. I think maybe this is not the system that I'm going to operate or see in the near future, but maybe 50 years later on, this kind of appearance of an endoscopy unit or an OR in the fiction probably will become reality. So I truly believe that we are only limited by what we can imagine. Thank you very much.
That was wonderful. Thank you very much, Philip. And thank you to our audience for signing in. As I would like to remind the latecomers, we'll now have a session for Q&A. So if you would have a question for Philip and you wanted to share it with us, please use the Q&A tab to ask the question, and I will pose it for you or on your behalf to Philip. To start with, Mohammed asked the following questions, and I think you sort of touched upon the answer already, but I just thought I'd ask it again. Is intracorporeal suturing also possible with current model or the current system? So can you do it now?
Now, I think the current system for clinical trial is not designed for intracorporeal suturing. It is only a research prototype that we are trying to achieve that. So, but I think this is kind of, endoluminal suturing will definitely help us in terms of managing complication, for example, perforation, managing bleeding, or even without any complication, if we can close the luminal defect after resection by suturing, then the patient can be discharged earlier, and we are not so worried about delayed bleeding. So I think this is an essential tool for future development of endoscopic robot.
But not one that is mature yet, basically, which I think is the key point.
Not yet, not yet.
Yeah. So we also have a question here. It says, what are the current outer diameter, or what is the current outer diameter for the endoscope and the instruments? So how big are they? And what is the acceptable maximum outer diameter for an ESD robot scope? So it's two questions. The first one is what the current outer diameter for the endoscope and the instruments is. And second, what would be the most acceptable or the biggest possible diameter for an ESD scope?
I see. So I'm not in position to tell the diameter or the size of the robot arm of the Endomaster, but in general, my concept, for example, like the USGI transport, the diameter is around 17 mm in size. So this can actually be put in as tested previously for the USGI transport to be used in upper GI and the lower GI procedure. So I think that is probably the maximal size that can be acceptable. So like 17 or 18 mm in size in the diameter. So I think for the robot arm, the smaller the better, of course. But it has to be balanced between the usability and the flexibility.
And on a slightly related note, can any of the instruments retroflex, at least in the stomach?
Yeah, good question. But in fact, the Endomaster can be retroflex, but it's not in a very impressive kind of retroflexion. So if we are going to use this system, for example, like treating the proximal cardia or the fundus lesion in the stomach, it's kind of very difficult. But at this moment, also the kind of early gastric cancer being occur at the cardia is low in incidence, and fundus almost like never or very low incidence. Most of the early gastric cancer occur in the distal part.
Yeah. Okay. Oh, George has a question, and he says, maybe I missed it. I don't think he did. But is the system attachable to any existing endoscope? And also, is the system, which one of the systems? Because you presented a few, but are any of the systems, platform technologies that can then be used with any endoscope?
I think the Endomaster system is a totally redesigned scope and also robot arm. So they are separate. So they are independently developed platform. For our CHK's robot arm, it can be used in a commercially available USGI transport, but not other endoscope, because other endoscope, the channel is too small. And I think the other system also have probably a redesigned platform, like the endoscope from the ERCAT IXU. I believe that is also an independent platform. So it's kind of difficult to just build on the existing platform. For the first generation of the master system that we use for the gastric ESD, that robot arm was built on a conventional double channel flexible endoscope from Olympus, but we can see the limitation of just using a conventional endoscope with a limitation in the size of the channel that we designed the robot arm. So that idea was abandoned in the subsequent development.
Understood. Okay. Oh, another question before I ask one burning question myself, and that is, what do you think is the best master control for gastroenterologists? Is it the same that you would suggest for surgeons? That's an interesting question.
Yeah, I think that's an interesting question, because a surgeon is trained now to use the rigid robot, for example, that they are very now used to using the two fingertip and the hand to control the robot arm. But a gastroenterologist is usually using the wheel on the endoscope. Yeah, so that's a major difference in the control of a kind of a robot that we are now having. So I've been asked several times whether a surgeon is better suited to use this system, or actually a gastroenterologist can be trained also with the use of this system. So my answer is yes, I think both can use this system. It's just a matter of training and how you get used to that control of the robot arm. Of course, this is a totally different concept as compared to a conventional ESD. So you probably have to relearn this approach and the technique. But once you be able to learn it, then I think the control is not a total problem.
Understood. So Philip, when you're using these miniaturized effector, robotic effectors, do you ever come to get to a situation where the robot is not providing you sufficient forces at the tip to manipulate the tissues as you would from a clinical point of view. So is there still a technological limit to the platform given how small the devices have to be to fit through the flexible lumen?
Yeah, I think this is also an essential question. And during the process of development, this is always come up and ask whether this tissue manipulation is good enough to lift up the tissue. So that's a key question. But well, in fact, it's the kind of mucosa that you need to grasp and lift up is not require a lot of force. It is a rather small force that you need to actuate and lift up the tissue. But the grasping mechanism is also important because how tight you can grasp, not tearing the tissue apart while gripping it, tightly to lift up the tissue is the key. So in the process of research, we also go through using prototype to grasp the tissue in a explanted porcine gastric mucosa model and try to test if we are going to tear apart the tissue or not good enough force.
So in fact, there is a question here that ties into this, and is the master control interface, do they have haptic feedback? And if so, what are the user comments? In other words, is there value in taking measurements from the scene and then replicating on the surgeon's hand? And if not, or if yes, what is the comment from a clinical perspective?
There's no haptic feedback. I mean, even the Da Vinci do not have a haptic feedback. So if you want to provide the accurate haptic feedback, I think the cost will be much higher.
And from a clinical point of view, do you think it will be a welcome add-on, almost irrelevant, or a necessary condition for a system over a platform technology of the future?
I think from the clinician point of view, at this moment, we are not doing so complex robotic procedure. So haptic feedback may not be necessary. So haptic feedback is probably important for the future automation. If you are thinking about using AI, then I think they will need a lot of sensing technology to enhance the tissue manipulation, total automatic. So for us, I think our eyes and our feedback and our experience compensate everything. But maybe the automation by the robotic require that.
Yeah, I agree. So Maliha has a question too, and it's that during the surgery, will you be capable to switch the end tool, or is the robot designed for this specific surgery with only uses grippers and ablation tool, for example?
At this moment, yes, we are only using the grasping and also the cautery dissection or the ablation tool. That's the only two instruments that we require for the procedure. So it is also not interchangeable. So left arm must be lifting, right arm must be cautery.
And in your clinician dream scenario, would that be a capability that you'd want the system to have? Easy exchange of instruments on the fly. So it's a limitation of the technology, and as an engineer, I can see why they have to somehow clamp things down. But from a clinical point of view, would there be advantage to this? Yes, unequivocally. Okay.
Yes.
So that is this one as well. I've got during the surgery. No, this one we've done. We've got. It seems this Endomaster system will escape the luminal boundary in the near future. Thanks, sir, for the comment and presentation. Oh, sorry, that's not a question. That was a comment. Okay. So one more question then, which is the following. In terms of clinical workflow, do you see an ESD robot as another feature for the regular screening endoscope, as a modular continuum device all in one, or is it a completely different scope used only in referred cases, large, flat, seared, and so on? So all in one with your diagnostic tool, or two different platforms?
Yeah, I think this question comes back to my turning point slide of whether you want a disruptive endoscopic platform or building the robot arm basing on current technology, because the current system that is applied to clinical are totally redesigned platform. They are not designed for screening endoscopy or ordinary common practice endoscopy. They are designed for treatment purpose. So it is a totally different kind of system. But I think I can see that there's also a potential of combining ordinary endoscope together with the robot system. That is because that will be more cost effective for a endoscopy unit to have one endoscope for all.
Absolutely.
So I think these are the two directions at this moment that we are trying to explore. I mean, in parallel.
Yeah. So you see, one of the big things about this area is screening, because we know the prognosis on patients which are caught early is significantly better. In fact, inordinately better. And now, within the context of COVID, the pandemic, the difficulty to do screening the way you are supposed to, do you think technology such as this would be helpful in trying to get through the large numbers of potential patients, right, in a slightly more controlled way? Or do you think we already have what we need in order to get through the numbers, especially as it gets harder to get patients in clinic, and we've got this massive and growing list of patients that they're still waiting, almost 1 year on?
Yeah, I think the whole world is facing this issue. So I believe, especially for developed country, screening program is almost supported by all the developed country. I think in the West very obvious that colorectal cancer screening is being supported, and is an ever increasing number of patients that is waiting for the screening colonoscopy, and also at the same time, there are some patients who cannot accept the current technology because of the discomfort they imagine they may be facing, and so that they don't take the screening endoscopy, resulting in advanced cancer. So I think we probably need a technology development in this perspective as well, to ensure good patients acceptance, management of high volume of patient for screening, and at the same time with a better patient's acceptance.
Yeah, I completely agree. Thank you, Philip. My last question, and then I'll let you go. From a business point of view, now you clearly presented a few platforms which are at different stages of research and development, and some products. Now, do you think any of the current products will make it into the big leagues and will be the sort of de facto standard in this type of procedure, or they're sort of still quite niche and is a long way away before we can get a product mass utilized in the field?
I think the Endomaster system is currently pushing towards a marketable product. So that's why we are doing the first clinical trial, and the startup company, I think, have the ambition of moving to the market in maybe 1 to 2 years time.
That is brilliant.
Yeah.
Wonderful. Philip, thank you very much. I think we are at the end of our allocated time, but I just wanted to thank you and the audience for engaging with us today, and remind everybody that the video recording of this keynote is going to be available on the Hamlyn Symposium website in the next couple of days. So for all of those who have not been able to be here with us live, please point them in the direction of our YouTube channel. So thank you, Philip. Thank you, everybody, and have an enjoyable rest of the day and
thank you.
Enjoyable summer. Philip, talk to you soon. It was a pleasure.
Thank you very much. Okay, bye-bye.
Bye, Philip. Bye, everybody.
Take care. Bye.
Peace out.